Welcome everyone to the webinar on Women's Health in Protracted Crises. I am Maria Kusa, the Division Manager of the GHI Academy. The Academy is the capacity building arm of the Global Health Institute at the American University of Beirut. This is the second installment of the webinar series on gender and global health. The webinar will be delivered by Eva de Plecker. Eva is a sexual and reproductive health referent at Médecins Sans Frontières, MSF in Belgium. Since she joined in 2004, she has worked in various sexual and reproductive healthcare projects in low-income countries such as Rwanda, Ethiopia, Indonesia, Darfur, Zimbabwe, Democratic Republic of the Congo, and Haiti. In 2011, she became a sexual and reproductive health advisor in the headquarters of the MSF Operations Center in Brussels. Eva will be delivering her presentation, which will then be followed by a 10 to 15 minute Q&A session. So I encourage you all to ask your questions as she goes through the presentation. There is a Q&A box. Please feel free to type in these questions as we move along. So without further ado, Eva, the floor is yours.
Okay, thank you, Maria. So good afternoon. I will present on assuring access to reproductive health services in a protected crisis, a Médecins Sans Frontières experience in Lebanon. So first of all, I will explain who is Médecins Sans Frontières, or also known as MSF. So MSF was founded by a group of doctors and journalists in Paris in 1971, following the war in Nigeria. Today, MSF is a worldwide movement of more than 30,000 health professionals, but not only health professionals, also logistical and administrative staff who save lives and really aim to alleviate suffering in more than 70 countries worldwide. So what is our charter? What is our mandate? Where do we stand for? MSF provides medical humanitarian aid based on needs, regardless of the race, religion, or politics, or any other political influences. What is important to know is that we do not take sides. We will negotiate access with everyone and are protected by our transparency, impartiality. So what are now the different sexual reproductive health components? Which are the different activities that we implement in our project? First of all, we offer antenatal care. This is the care that is provided for women throughout their pregnancy. Then postnatal care. This is the care for mothers and babies after delivery. Family planning. Various methods are offered. Also treatment for sexual transmitted infections. Care for victims of sexual violence, safe abortion care. This is care for post-abortion related complications, but also termination of pregnancy on request. We also offer emergency obstetric and neonatal care. We treat female genital mutilations and complications related to that. Also care for fistulas and HIV prevention through mother-to-child transmission prevention, and also cervical cancer. So what is now the volume of these different SRH activities in MSF? And I will present you the 2017 data. First of all, the overall total of deliveries, more than 280,000 women delivered in our project, and this is being offered in 119 projects. So if we look at the overall total deliveries, 10% of these women deliver by a cesarean section, and this is in 71 projects. Not only deliveries, also abortion-related complications. More than 22,000 women came with abortion-related complications, and this is offered in 93 of our projects. Then the whole preventive package, antenatal care, postnatal care, and family planning, and you can clearly see that antenatal care has the highest attendance, but you see that the overall total number of projects are quite similar. And this is because mainly when we offer antenatal care, also postnatal care and family planning is offered. And as last, the volume of sexual violence care, more than 80,000 victims came to access our services, and this is implemented in 133 projects. So how do we prioritize? Because you saw that in the previous slide that if we look into sexual and reproductive health, there are many components to implement. So this policy guides our different missions in the prioritization of the different sexual and reproductive health activities. So first of all, this policy lists the different actions which have a direct impact on maternal mortality, as obstetric, newborn care, and safe abortion care. Second, the preventive action, the different preventive activities like antenatal care, postnatal care, and family planning. And as last, sexual violence care and female genital mutilation. Meaning this policy is divided in 3 parts, and according to these 3 titles, the different activities are listed. So for this presentation, we are going to go to Lebanon. I assume that for the majority of the audience that is listening, it's a country that is known to them. So Lebanon is located in Western Asia. It's bordered by Syria and Israel. It's one of the most religious and diverse countries in the Middle East, and it has a population of 5 million. What is very important to know is that 1 out of 5 citizens is actually a refugee. And it's also a context where an estimated of 1.5 million Syrians have sought refugee. So for this presentation, we will present on the comprehensive sexual and reproductive health care package that is offered to Palestinian and Syrian refugees in Beirut, women who are currently today living in a protected crisis. So this slide presents the different MSF projects in Lebanon. You can see that MSF works all over the country, from rural to urban. We offer services as pediatric care. This can be at primary healthcare level, but also intensive care. We offer care for non-communicable diseases. This can be done ambulatory, but also through mobile clinics. We offer care for vaccination, for mental health, and then the comprehensive package of care of sexual and reproductive health, which I will elaborate further throughout this presentation. For this webinar, we are mainly going to focus on the projects that are located in the south of Beirut. If you can see the map, then you see here on the left side a blue circle, and these are the projects in South Beirut. All the other red circles are the locations of the other projects. So South Beirut project is located in one of the most vulnerable areas in Lebanon. MSF works in 2 Palestinian refugee camps. One of them is Shatila and Bur el Barash. The camps are not linked to any Lebanese services, and they're also characterized with poor infrastructure and fragile security. Because of this fragile security, there are multiple forms of violence, and there is a very vulnerable mixed community and population that is currently living in a very precarious living condition. So here you see 2 pictures of the Shatila camp. I think it speaks for itself, meaning that you really can see that there are problems as overcrowdedness, there are poor living conditions, and you can also see that the basic needs are not met. The following pictures are also from Shatila. You can see the same. You really see that there are poor infrastructure and poor living conditions. So what are now the 3 locations of the MSF projects in South Beirut? Our first project is located in Shatila, and Shatila project offers, so we have a primary healthcare center where we offer care for non-communicable diseases and vaccination. Shatila has the history of also having a birth center. This birth center is now moved to Rafik Hariri University Hospital. And currently, Shatila project is also still offering antenatal care, postnatal and family planning, and this will move this year to Bul el Barash location, where MSF will establish a family center. The project chose to name it a family center and not a women's health center, because they really emphasize to promote women's health care for the family. I will also explain later on, because there have been various initiatives, like for instance, male involvement in family planning services. And as last, we have a third project, and this third project is located in Rafik Hariri University Hospital, where we have actually a birth center. This birth center is based on a midwifery model of care, which means a demedicalization of deliveries. This means that normal vaginal deliveries are occurring in this hospital birth center. So now, what is the project strategy? So first of all, we aim to integrate a comprehensive package of reproductive health care for women living in protected crisis. This we do by integrating sexual and reproductive health services into its primary healthcare package, and this based on the various clinics offered by MSF. These SRH services, they include antenatal care, postnatal care, and family planning. But not only the service, also we integrate a community approach, because we believe that it's super important to raise awareness about family planning methods and also about the importance of women's health. So here you see a picture of one of our midwives who actually talks to a patient after the antenatal care consultation. And here you have the example of the waiting area of the antenatal care services. And here you have another midwife of our team who proudly presents a baby which came with his mother after delivery for a postnatal care checkup. So these were the different services, but we also emphasize on a community approach where we focus on reproductive health awareness. These two pictures are located, are taken from in Becca. This is another location where MSF also offers sexual and reproductive health care. And Becca is known as a location where refugees live. And the lower picture that you can see, this is on family planning sensitization that is done by one of our colleagues at community level with the patients and women. So this is an example of the BAIL sensitization of family planning services. This is one of the components also of the family center. We believe that it's very important to empower couples and that this can have a positive influence on family planning uptake. Many of these men, they are not well informed. First of all, they're not always informed that they can join their wives for a family planning consultation. But many of them are also misinformed. They are misinformed about different family planning methods, and this can influence also the family planning uptake. There were focus group discussions done with the men that came with their partner or their wives, and one of the comments they also gave is that they are willing to accompany their wives, but sometimes it's difficult because it's during working hours and then they need to take a day off. So the project wants to establish new opening hours that are compatible to men's working hours. So the second strategy of the project is the midwifery-led model. So first of all, I will explain what are now the main principles of such a midwifery-led model. So in a midwifery-led model, non-complicated deliveries, meaning normal vaginal deliveries, and newborn care, they are performed at the clinic by the midwives. If a complication occurs during labor, these patients are timely referred to hospitals, meaning secondary line care, so they can have access to cesarean section if required. So how did MSF establish now this birth center? What was done in practice to make this realized? So in May 2018, there was a memorandum of understanding, an MOU, an agreement signed with Rafik Hariri University Hospital. This agreement stated that MSF will run a birth center at the Rafik Hariri University campus. This means that the birth center is located in the campus of the hospital. This, the hospital and MSF, we agree to combine our capacities with the main emphasis on the importance and also on the relevance of this midwifery model of care. So because we can understand the principles and we can understand how MSF established this collaboration with the hospital, but now I really want to explain in practice how is this being done. So women come during pregnancy for antenatal care in the family center. So if during pregnancy there is a complication being detected, for instance, a patient who is diabetic, or if there is a patient that comes for antenatal care with a risk factor. A risk factor can, for instance, be a previous cesarean section scar. These women with already predefined complications and risk factors, they are advised to immediately go and deliver at hospital level. So they will not pass the birth center. Patients who have a normal pregnancy and when there is no complication being detected, they are advised to come and deliver in the birth center. When they deliver in the birth center and there would be a complication detected, then our midwives are trained to do timely referral to Rafik Hariri University Hospital. This is the first hospital because it's also logic because the birth center is located in the hospital. So the distance for referral is closer, but sometimes we also refer to partner hospital. Both Rafik Hariri University Hospital and the birth center, they will refer patients for postnatal care and family planning for follow-up. So what is now the project data? So in 2018, the project consulted 1,906 women for antenatal care, and we have a monthly average of 221 deliveries in the birth center. Of these 221 a month, 11% are referred for delivery, meaning referred for to the hospital. It's important to know that these referrals, these 11% of women that are being referred, these are women that normally were intended to deliver in the birth center. But during delivery, there was a complication that occurred and then they are referred. There is still the other group of patients that I explained earlier on that develop a complication during pregnancy and they are directly referred to the hospital. MSF also takes them on charge. We support delivery, referral, and we follow up the referrals. But these referrals are not presented here in the data. Additional postnatal care and family planning consultations, more than 1,611 women come in average a month to access these services. And there is a family planning uptake of 36%. However, we think that this is still underestimated because there are even more women coming. Because some women, they come first for information, and that can be once or twice or 3 times. And some of them, they also say, okay, now I understand the different family planning methods, but I prefer to return with my husband. So actually the overall total of family planning consultations is even higher as here presented. So all babies that delivered in the birth center have been born alive, so there were no neonatal deaths. And 3.2% of the babies were referred. So a birth center also has the capacity to reanimate the newborn, to stabilize the newborn in case of complications, and then to facilitate the timely referral. So here you see the waiting area of the birth center. And here you see one of our midwives examining a newborn after birth. And here you see the midwife proudly handing over the baby to the mother after a normal birth. So I want to thank the Global Health Institute to give MSF the opportunity to present at this webinar. I also want to thank all the different projects and field teams in Lebanon to care for women at our project levels. And in case of interest, there are two emails here on the screen. First email is from our medical coordinator, Wilma. So in case of any questions, you can always contact her. And also my email. Myself, I'm based in Brussels. I'm not working in Lebanon. But if you would have any particular questions related to the project, I can always try to address the question or guide you to the right person. I want to thank you.
Thank you, Eva, for this very insightful presentation. So I think we'll start by taking questions. We already have a question from Rasha, and it's, do you think this midwifery model can help in reducing the CS prevalence among refugees?
Yes, definitely. You know, the midwifery-led model is a model that is well known, and it's also widely studied. There is an interesting Cochrane review on this midwifery-led model, and it includes 15 trials, and it has more than 70,000 women included. And there, in the primary outcome was that women who deliver with the midwifery-led model, they have a higher likelihood of a normal birth. They have less chance to have an instrumental delivery, and they have less chance to have an episio. And also there is more patient satisfaction. I think everybody who works in reproductive health knows that once you have a cesarean section, there is a high likelihood to have a second, and then the third one also. So I think by this midwifery-led model, you give the women also the chance of a normal vaginal birth, and it can also reduce the C-section rate at country level. I see another question.
Yes, so I'm happy to read the second question. So it's, can you speak to conducting research in a crisis setting? For example, have you studied the effectiveness of different SRH interventions in these settings, or how interventions should be adapted for humanitarian settings?
Yes, I think MSF has studied you know, various components, but I don't really know if I understand the question. So it's, for example, have you studied effectiveness of different SRH interventions in these settings? Does the person mean globally in our different projects around? Yeah. So maybe I will leave this question for a few minutes, and I will address first the other question. So the other question is, based on MSF experience in terms of male participation in family planning, what are the main challenges raised by men regarding family planning or birth control? What we mainly heard also on these focus group discussions that we conducted with the men is that there is a lot of misinformations. We know this all, right? There are a lot of myths around family planning, that if you take certain methods that it could lead to infertility, etc. And one of the main challenges that the men raise is that even if we are interested, we are not always involved. And there is no option for us, or it's more difficult for us to attend the services. So what mainly was raised was the lack of information, the misinformation, and not to have services that are adapted to the consultation of the family, and not only to the consultation of the patient and of women. So they mainly asked, you know, to adapt the opening hours, to make it more male friendly, and to strengthen this awareness and to involve men. Okay. The other question is, I'm interested in the unique challenges of doing research and wondered if you have experience integrate into the project you described. Yes, I think one of the researches that recently in this project was conducted was this qualitative research on male involvement at family planning services. and this will be soon also presented. There has been an abstract submitted to a scientific conference. And of course, yeah, this midwifery-led model is still young. We started in December, so we are definitely interested to research it better and hopefully in 1 year or longer to do an analysis on the outcome of births and neonates and hopefully to publish this also. Because there is indeed a lot of research on midwifery-led models, but it would also be unique to document it as an experience in Lebanon and to document it also for a refugee population living in a protected crisis. The other question is, what are the main birth control strategies MSF supports in field projects? In the majority of our projects, family planning is offered, and we believe that it's important to offer a wide variety of family planning methods, and not only the oral or the injectables. If you really want to have a qualitative service, then you have to have a variety of methods. As explained during the presentation, we strengthen awareness, sensitization. We offer family planning through mobile clinics. And another birth control strategy is that we try to avoid the missed opportunities. Because sometimes family planning services, they are only linked to women's health care, meaning to antenatal care and to deliveries. But in this MSF, we also try to strengthen, for instance, family planning being available in nutrition projects or in an HIV project. So we work on the availability of the services, on the quality, on the sensitization, and on the integration of family planning in other services that are, for instance, also not only related to women's health care, to work on the missed opportunities. I see here another question. Maria, can you assist me on the last question? Can you read the last question, because the screen
Yes,
is...
definitely. So there's 3 questions that came in. So I'll start with the first one. So this is from Stefan. I'm very pro midwifery-led model living in the UK, and those who are low risk, are the outcomes similar between the birth care center and the RHUH? Would be excited to see your paper.
Are those who are low? Yeah. Unfortunately, it will be difficult for me to answer your question now. What I do know is that in our low risk cases, we have 11% of referrals. What is fairly normal, but I have to say that I don't know today the exact percentage of complications of the high risk. So unfortunately, I will not be able to answer your question, but we could, later on address this question. And the paper is not ready, because you're also right, we would be excited to see your paper. Of course, this all still needs to start, and it's definitely not ready, but thanks for your interest.
So shall I read the second question?
I think the second question is mainly asking on doing research on refugee health through a PhD. Maybe this is a question that could be rather addressed by mail, and the person could always write us to ask more specification how to partner up or what can MSF offer regarding research. Maria, was this the last question, or do you see
So there's three more questions. So we'll be taking the last 3 questions. So the first one is, has MSF implemented any project or intervention focused on sexual education, health promotion, and prevention among adolescent refugees? If so, what are the main challenges you have found?
Yeah. Yes, in MSF we have also projects that are specifically working on adolescents. It has, I have to be honest, that really project that focus on adolescent refugees, this is less, but for sure in our refugee projects, we see adolescents and their sexual education and health promotion and prevention is being offered. What are the main challenges? I think it's similar. We need to adapt our services and we need to be creative. In some of our adolescent projects, we work with adolescent hubs. That means a room or a gathering place where adolescents can join and where we share information and where also we can link them up to services. Other strategies that we apply for adolescents are mobile clinic activities, or we try to identify a senior adolescent, and this person is then, you know, the communication person between the adolescent population and the MSF facility. So yeah, the challenge is the creativity and that you need to adapt your services to the type of adolescents that you see, because from context to context and from country to country, they can face different challenges and needs. But this package of care that we offer, that is mainly standardized, and that is similar to the package of care that I described here, the preventive package, and also to identify pregnancies and to assure that there is a safe delivery and that adolescents can also access qualitative healthcare, sexual and reproductive healthcare services.
So the last two questions are related to services at MSF. So the first one is, do you offer LARC methods, especially IUD insertion? How is the receptivity for such methods? And the last one is, do you offer birthing classes during antenatal care? What other services do you provide?
Yeah, IUD insertion is one of the methods. So for one of the long-lasting methods, we offer implants and we offer IUDs. The IUD is receptive, meaning that patients accept. It's not maybe the most popular method, and it also varies from context to context. In some of our missions or countries where we work, it's totally not popular. But for instance, in the Middle East, IUDs are more popular compared to Africa, for instance. Yeah. But it's one of the methods that we offer in almost all our projects. Yeah. And then, do we offer birth classes during antenatal care? This is maybe less. I know one of our projects where we actually offer birth classes, but this is specific for women being pregnant out of rape, where we actually offer specific birth classes to support these women throughout their pregnancy. But it's not a standard activity that is offered by MSF. But what we do in our antenatal care is to sensitize. We sensitize on how to prepare for birth, what is a safe birth, which complications can occur, when do you need to come. But we don't do the classic birth classes where you, for instance, learn how to breathe or how to manage contractions. This is not something that's standard we integrate.
Wonderful, thank you, Eva. I think those are the questions. So for anyone who's interested in following up with Eva offline, she has her email on the last slide. I'd like to thank you all for joining us this afternoon or morning, depending on where you're joining us from. Thank you, Eva, again for this really engaging and interactive. And I'd like to encourage you all to, if you haven't done so already, register for the last webinar of this series, which is going to be held next Thursday, and it's on gender-based violence in global health.